Do you want to say a few words, Vishali?
Morning, David.
Hi,
Hi,
everyone.
David.
Uh, the
Hi.
team has to let the attendees in. They are in the waiting room. So let's wait for a minute for
Okay.
everybody to join.
They have my name as Fahihi. I don't know why. That's my fellow.
Yeah.
I was just going to ask, where's David? Is he using somebody else's computer?
Maybe
You probably
rename
use
it.
his or her link.
Yeah. Maybe the global team can change it.
David,
No,
you
it's
use your
not
fellow's
letting me.
name.
It's not changing it.
Oh,
I
this
think
is
maybe they can.
really messed up, guys. I'm having a big problem here. It changed format
Should
on
we?
me something while I wasn't looking. This is crazy. Just
Do you want us to go with cases first and then have Janet bring
Yeah.
up
Why
the?
don't we
I
do
think
that?
that may be better,
Yes.
so we're not delayed. At least one case or something. Yeah, that'll be fine. It's just
You're online.
I don't know. This is really annoying. I think I've got a solution here.
So, Janet,
That
we will
give me
begin.
1 second here.
Yeah, you can take your time. A very good morning, good afternoon, good evening, and thank you for joining for 15th Grand Round session on non-infectious posterior uveitis. Very thankful to our education team being led by John for doing these monthly webinars. And with this, I would pass it on to John for today's webinar.
Good. Well, welcome everyone. And today we're going to talk about what has historically been called white dot syndromes. And we're having a little technical difficulties, so we're going to start in a little bit different order than usual. But we look forward to some very interesting cases. Thanks I think everyone who's presenting got up very early in the morning, so thank you very much for doing that. Can we start with your case, Sapna?
Sure. Russell Din, my fellow, vitreoretinal fellow, senior vitreoretinal fellow, is here, and he'll
Okay.
be presenting the case, and I'll follow with the discussion.
Okay, so Sapna Gangaputra is Associate Professor of Ophthalmology at Vanderbilt University and Director of Uveitis Service there. And we thank you so much for giving us this presentation about punctate choroidopathy, which is a rare and very important condition to diagnose. So thank you. And thank you, Russell, for presenting. Why don't you go ahead?
Thank you so much for having us, IUSG, for this wonderful series, for the Grand Round series. As you mentioned, my mentor and our speaker is Dr. Gangaputra, and I'm Russell Din. Let's see here. We have no relevant financial disclosures for this talk. Our case is an 18-year-old female who presents with a smudge in her vision for the past 6 months. She had no pain, no photophobia, no flashes or floaters. She was a high myope with some contact lens use, and her past medical history included hypothyroidism on levothyroxine, migraine headaches that was unmedicated, and no past surgical history and no relevant social history. On examination, she was 20/20 in the right eye and 2200 on the left eye. Her anterior segment was normal, and her refraction was -10 and -12, roughly. Here are color fundus photographs. The right eye is normal. The left eye has clear media. The nerve is flat. The vessels have normal course and caliber. The limited periphery appears normal. The macula has a hyperpigmented lesion in the fovea and a small hypopigmented punctate lesion in the infratemporal macula. Here is an early and late phase fluorescein angiogram. In the early AV phase, there is mild hyperfluorescence in the fovea surrounded by hypofluorescence, and this stains in late phases with some mild leakage. This is an old OCT cut through the fovea. There appears to be some subretinal mixed hyperreflectivity with no significant intraretinal fluid. So in summary, this is an 18-year-old female with high myopia with small yellow lesions and an apparent CNVM in the left eye. The differential diagnosis at this time included punctate inner choroidopathy, multifocal choroiditis with panuveitis, although she had no inflammation, myopic maculopathy with a CNV, tuberculosis, syphilis, and sarcoidosis, of course, the trio. So this patient was diagnosed with PIC, and you can see that highlighted elevated pigmented lesion, which was likely a choroidal neovascular complex, and the small hypopigmented lesion in the infratemporal macula. And so she was thought to have macular neovascularization and was started on anti-VEGF injections with a plan for a series of 3 injections. But she only received 1 injection and was lost to follow-up for about 5 years when she represented with like looking through a fun mirror in her right eye. And you can see the development of 2 small hypopigmented lesions in the macula in the right eye and several more in the left eye. OCT here, unfortunately, does not go through the lesion, but does show sparing of the macula in the right eye. Thus, because we don't have an active scan for her, we found a representative photograph of a similar patient. You can see here that in the near IR, there are numerous punctate lesions, and on the B scan, a focal hyperreflective subretinal and outer retinal lesion with loss of the ellipsoid zone, and that EZ disruption actually extends further than the lesion itself, and this represents an active lesion. Because we thought it was active, this patient was started on oral prednisone and given another injection of anti-VEGF medication. After a week, she began to improve symptomatically, and she began to taper on the prednisone, and a slow taper was conducted over several months. She was followed for a couple years, and 2 years later began to have new blurriness in the right eye, and you can see the development of more punctate lesions in both eyes. Again, we don't have an OCT through the lesion itself, so I found a representative photograph. This time, previously I showed you an active lesion. This time, we show one of the older inactive lesions with a focal ellipsoid zone and RP disruption, an increased choroidal transmittance, which represents an old inactive lesion.
One minute, Russell, I'm seeing a lot of comments. Is everyone able to see the screen? The comments are saying that they cannot see slides.
Yeah,
Oh,
I'm seeing
yeah.
the same problem, but I can see the screen nicely. But
Yes, I can
comments
see
are
them.
saying there is a
So the
issue.
comments, I'm wondering if it's really, we as panelists can see, but I'm seeing a lot of comments.
It doesn't seem like the registrants are able to see. Why do we have a global conference technician? Why is there?
That's not good.
Yeah, Russell, give it 1 second. I think
Of course.
a lot of people are saying they cannot see the screens and slides.
I can't even really see any chats other than the host chats.
You look at the Q&A. Look at the Q&A, under the Q&A.
Oh, I see here.
Yeah, it doesn't seem like any of the registrants are seeing the slides.
Hmm.
Is somebody helping us with the Zoom?
Can you stop sharing and then try to start sharing again? Is that a possible? Maybe you can reset it that way.
And I can also try to share if you
Surely
like for
try.
the lecture that was scheduled at 8. Maybe and see if it's a local problem or a general problem with the transmission. Would you like me to do that?
So do we send you our slides then?
Do we have a technician?
I think Vishali's on the phone with somebody, so let's see.
Can everybody see now that the screen has been reshared by Russell?
So the comments were saying that they were able to see the slides. He just has to swap the presenter view. They were seeing a smaller version of the slides. So Russell, you just have to swap to the presenter view.
But I'm seeing it perfect. I don't know.
Okay, now they're saying it's
Okay,
I can see.
I think everyone can see now. Do we want to go back to the beginning of the case?
I can just show some representative
Yeah.
photos from the case,
Yeah,
and that
Let's,
way,
Just a little
'cause I
bit.
think
Yeah,
everyone
just a
heard
little
me.
bit. Yeah.
go back.
yeah, just show the
Okay.
photos.
It's probably a local problem, not a general one, because we can see the screen fine.
It's okay.
A lot of people saying now better, so I'll go
Now
ahead
it's
and
okay. Yeah, now it's
Yeah.
okay.
show some photos. This was the initial photo. You can see the small lesion in the left eye. And this was the initial fluorescein. And then this was the follow-up photo 5 years later with new hypopigmented lesions in both eyes. This was the first representative OCT, which showed the focal hyperreflective kind of subretinal, outer retinal, and ellipsoid zone disruption. This is an active lesion.
Don't go very fast just because people need a few seconds to look at these things.
Okay. And you can see in the near IR photo the numerous punctate lesions. And here is here's the follow-up photo 2 years later after the prednisone, where the patient had new punctate lesions in both eyes. And so there were some original, the right eye was previously totally clear and then developed a few and now have numerous. And here is our second representative OCT. And this OCT, in contrast to the previous, which was a localized active area of inflammation, this represents a focal ellipsoid zone and RP disruption, which represents an inactive lesion. And actually, I think we're cut up, so that wasn't too bad. Does anyone need to go back and look at any of the previous photos?
I'll be covering them again in discussion, so go ahead.
Okay. So this patient, although I just showed you an inactive lesion, had other lesions that were active, and so she was restarted on prednisone, and which helped her bridge to methotrexate. She was thought to need long-term immunomodulatory therapy. So 1 year following that, after starting methotrexate, she presented with even more lesions in both eyes. And so she was switched to mycophenolate in an attempt to further immunosuppress her. So this is a progression, an 8-year progression of the right eye, where she initially showed no lesions in the upper left photo, progressed to just 1 or 2 lesions, and then continued to progress despite immunosuppression. And I think one of the nice features we see here is that the lesions tend to not disappear or regress after over time. This is the same progression over the left eye. And she was subsequently lost to follow-up for 5 years, which takes us to now, which hopefully means that she has been doing well and hasn't had much change to her vision. So in short, PIC is a primary inflammatory chorioretinopathology, which was formerly categorized under the white dot syndrome. It's a multifocal chorioretinopathy and frequently affects young myopic women. And it is characterized by this inflammation of the RPE and inner choroid. Patients typically have scotomas, blurred vision, photopsias, floaters, photophobia, metamorphopsia, and it can present unilaterally like it did in our patient, but usually it's bilateral or becomes bilateral. And with that, I'll turn it over to Dr. Gangaputra to help us learn more about PIC.
Thank you, Russell. Would you advance slides for me, please?
Yes,
So
of course.
this is the SUN, or the standardization of uveitis nomenclature classification for PIC. And this is something that we use it as the holy grail of how to diagnose PIC. So definitely always rule out infections, especially syphilis and sarcoidosis. If you live in a TB endemic area, then also TB. And these lesions are predominantly smaller in size, which is relative, and typically affects the posterior pole, but can extend up to the mid-periphery, and is characterized by very minimal inflammation in the vitreous and the AC cells. So you may see some vitreous cells, but you won't see 2+ lots of haze. So it's relatively pretty quiet. Next slide, please. So as he showed you, and I wanted to take some time to go over these images a little slower. So you'll classically see these smaller lesions. Now the lesions all might have slightly varying sizes, but typically all of them are circular, hypopigmented yellow in color, and then the older ones can look a little bit more atrophic with a little bit more clear margins, but that's a very classic appearance. These lesions are deep, and so it's very frequently that PIC lesions can lead to macular neovascularization. We used to say CNV, the retina world now calls it MNV, and so very frequently you'll see this. So always have a healthy suspicion in these patients to get an OCT or an OCTA. When looking for a case, we searched for one that had a very long chronic history. So we didn't have very good OCT images in the beginning, but we also wanted to show an FA, which we don't do very frequently these days. So this case, we kind of moved around time to really show you progression and all the multimodal imaging that can be possible. Next case, please. So is there a difference with PIC and multifocal choroiditis? Are they the same entity? Are they different entities, just different sizes? And there's a good amount of literature. And in fact, there are some papers that even say that a same patient can have PIC in one eye and multifocal in the other eye. So more and more we are realizing that it's part of the same spectrum, but they are phenotypically different. There are very classic features of PIC that may not be seen in MFC, but overall, imaging-wise, they behave the same. The activity of lesions looks the same. The complication rates for MNV are higher with PIC than multifocal, but overall have a higher degree of suspicion when you see PIC lesions for MNV, but these are typically female patients, typically patients who have myopia. And so those should trigger you to think about it. In the United States, we also have presumed ocular histoplasmosis that can look with lesions similar to this, but you'll have more other characteristic features of pose that may not be present in PIC. Next slide, please. So here's the lesion. This is from a manuscript that we just published, which was an IUSG publication looking at multimodal features of PIC and MFC. And there are two classic features of OCT that I'd like to bring to everyone's attention. One is where it can look, and you can see here, this is a scan. The green line is the scan through the OCT. And then you can see that there's the outer, I can't point, Russell, would you point for me? You can see that the RPE is intact, and then you have the ellipsoid zone that has a break, and right in the middle of that, you're seeing this inflammatory PED indicated by the red star. So this is a very classic appearance of PIC, and this lesion, you would consider this to be an active lesion. But as you look at the SLO image on the left side, you can see that even on the SLO image, the lesions look a little bit different. So same eye, same OCT scan. In the next slide, can you go ahead, please, to the next slide? And you can see here, there's a different lesion. This one looks a little bit more fluffy and like we call the shrimp, subretinal hyperreflective membrane. And so you can see that little with indicated by the red star. And again, pay attention to the break in the ellipsoid zone. The reason this is important is because even though the lesions are tiny, what the patient sees is loss of vision that's larger than the actual lesion itself. So patients are much more symptomatic, and their vision, the impact of this visual impairment is much more severe to them than what you might actually catch on an OCT. And so a couple lessons that I want to impart here. Even we did this in the past. We used to only get a few raster scans, as you saw in the images we showed you from 13 years ago. And if we had only done raster scans through the fovea, we might have missed many of these. So one of the things I want to impress upon everyone is if you have access to OCT, if you're anyway getting an OCT scan, you might want to try to image the active lesions or what looks like active lesions. So by colors, and you can actually then identify what the characteristics of the lesions are, because OCT is the most sensitive imaging modality to show us activity of PIC and MFC. Next slide, please. And here is the same eye imaged over 2 different visits, and you can see how there was an active lesion on the top slide indicated by the red star and the break in the ellipsoid zone. And then later on in the second one, you can see when this lesion becomes inactive. The point I'm trying to make here is even after these lesions resolve with treatment, you might never go back to complete normalcy like you might see in a MEWDS patient where the ellipsoid zone may reconstruct and everything goes back to normal. These patients may have long-lasting visual impairment or scotomas way past when the eyes are inactive as well. So this is an important differentiation for us to be able to use OCT scans to identify if a lesion is active and then monitor them, because when patients have relapses, it can happen in 2 ways. You can either have a brand new lesion that didn't exist before, like Russell showed those examples where there were new spots appearing, but with PIC and with multifocal, many times the same lesion in the same area can reactivate. So you really have to focus when you're getting your OCT scans, you have to focus even on the inactive lesions because a relapse may present in the exact same anatomic location. Next slide, please. So here, I again want to impress upon everyone that the major cause for vision loss is from the long-standing, the chronic lesions, and often it can be accompanied with MNV and subretinal fibrosis. And this subretinal fibrosis is not expansive, it's very focal, but it can really affect visual acuity and long-term visual impairment for the patient. Next slide, please. OCT angiography, we're seeing, more use of it now. I will say that I still particularly would use an OCT to determine whether a patient should get an anti-VEGF. But I've had some patients where when I do an OCT angiogram and I see the neovascular net, and sometimes I see the neovascular net expanding in size, but there's still no exudation. And at that time, you have to take in other clinical characteristics. Is the patient bothered by it? Is it visually impairing before you decide to do an anti-VEGF injection? But most times, if you see a net and you see subretinal fluid on an OCT, then you're more likely to give an adjunctive anti-VEGF injection to that patient. But if I typically see a lesion growing, I would rather treat that patient with an anti-inflammatory medication before I go to anti-VEGF. But I'll discuss those in treatment as we go along. I just wanted to show you that when you do an OCT angiogram, you really want to be looking at the choriocapillaris area to actually look for these CNV, MNV membranes. Next slide, please. So this is really important about how do we manage these patients. And I've seen several patients sent to me who are chronically treated with Q2 months or every 2 months or every 3 months with an anti-VEGF injection because, sometimes people treat it like you would for macular degeneration. So patients with macular degeneration, we don't stop the anti-VEGF treatment, you keep treating it. But in PIC, same as myopic CNV, you don't necessarily have to keep treating the CNV lesion. More important is to treat the inflammation. And when the inflammation is quiet, we hope that the CNV will also quieten down. You may sometimes need to support the CNV by also treating with anti-VEGF, but it's not a chronic anti-VEGF treatment. More importantly, you have to think about, does this patient need chronic anti-inflammatory treatment? And there are many patients who you can give them an Ozurdex, or transiently you can do a burst of oral prednisone, and that may be all that they need to stabilize and be quiet for many, many years. So this is not one of those patients where you look at it and say, I know this patient is going to need chronic immunomodulatory therapy. You actually have to follow the patient over time, monitor the number of relapses they have, monitor how close the relapses are to each other, and how this is visually affecting the patient. Dr. Saraf, do you have your hand up for a question?
Yeah, I just wanted to quickly mention, Sapna, that the case was a beautiful case, but just in terms of therapy, I think the value of OCTA is when you see those Schrem lesions, you don't know if they're inflammatory or they're CNV driven. And so by doing the OCTA or the dye-based angiogram, but the OCTA allows you a more practical differentiation where you see a new lesion, you can quickly get the OCTA. If it has flow, you can treat with anti-VEGF therapy. And in fact, I have several young myopic female PIC patients where these lesions, these active Schrem lesions, like the eruptive one you showed in the second slide, actually, you just give them an anti-VEGF injection, maybe 2, maybe 3, the lesion regresses, and they're actually stable for many years and may not actually need immunomodulatory therapy. So I think that's one, maybe variation in how I approach these patients. Certainly, if you see recurrent inflammatory lesions, there's no flow, then I think immunomodulatory therapy makes sense. But sometimes it's just recurrent CNVM, and anti-VEGF therapy may be sufficient. And as I say, I have a number of these patients who have remained latent without recurrences for many years, just with anti-VEGF therapy.
Thank you, Dr. Sarafi. I really appreciate
one
you
other approach to consider.
Thank you for clarifying. I really appreciate that. Next slide, please, Russell. So if we were treating the inflammation, what we would do, typically corticosteroids, oral corticosteroids, there's no role for topical. You could also do regional. I've had patients that I've managed with regional Ozurdex, but typically you would use oral corticosteroids, and most of our corticosteroid protocols will start at 1 milligram per kilogram, no more than 60, and then taper that over some time. But remember that if a patient has frequent relapses and you're frequently treating them, then you really want to consider immunomodulatory therapy. Most commonly, I begin with an antimetabolite, either methotrexate or mycophenolate, depending on the patient's preference, age, other systemic factors, and other social factors. If they like to drink alcohol, maybe methotrexate's not the best choice. If they're young and in the reproductive age, we really need to talk about mycophenolate. But for most patients, I would typically start with methotrexate. And very rarely, if there are contraindications, then very rarely would I start with adalimumab as first line. Typically, adalimumab for me is always a second line agent, which in my PIC patients, I'm very, very rarely going down to adalimumab. Most of them are really well controlled. And as Dr. Saraf said, often most of these patients do not have chronic courses. The case I showed you was kind of atypical to see someone with such a chronic course and relapsing lesions. Most patients have acute relapsing inflammation. Next slide, please. And I just mentioned there about anti-VEGF. Very rarely would someone need chronic injections. Typically, we would treat them with 1 to 3 anti-VEGF injections, which seems sufficient to control that specific event until the next time it happens. But I do follow these patients every 3 months, even if I'm not treating them, just to monitor them, because as you noticed in our patient with the left eye, she did have many new lesions, but given that she already had central visual impairment, she didn't really complain about much changes in her left eye. She only came to us when she had changes in her right eye. So these patients are very much at risk of loss to follow-up if they have a macular scar already. So I try to monitor the patients as much as possible. PDT has been reported as treatment. I will admit I don't even know how to do PDT, so I don't use that. Dr. Saraf, do you use PDT for any of these patients that have
No, I think anti-VEGF works so well that it's very rare that you would not need to go to PDT.
Right, sounds good. Thank you. So same, I would use anti-inflammatory medications if required and anti-VEGF injections as needed for a patient, and that's what I seem to do for most of my PIC patients. Next slide, please. So unless the fovea is involved, patients typically do really very well, which is, as I mentioned before, more risk of them being lost to follow-up. So you have to impress upon the patients that relapses can occur and they do need monitoring. Next slide, please. And here are my references. Happy to answer any questions. I see that there are a few questions in Q&A. I will respond to them when the next speaker is presenting. Thank you.
Okay. Well, thank you. That was a beautiful case. All right, now we're ready to go with our thematic lecture. So Janet, why don't you get your slides ready? So Professor Janet Davis is very, very well known regarding many aspects of uveitis, including the spectrum of disease we're talking about today. She holds the Leach chair at Bascom Palmer, and we really appreciate you speaking with us today, as well as all of the other faculty. And so thank you very much. And why don't you go ahead and start, Janet? In the meantime, let me just comment the CNV, I think, is the most common in PIC of any uveitis condition, and bilateral CNV is fairly common in these cases. So it's very important to be vigilant for that.
Okay, so this is supposed to be an educational conference, so I'll just make a comment. Never try to do a few updates right before the talk. Right now, the computer is forcing me to upload to OneDrive before I can give my presentation for an unknown reason. So if this doesn't finish here in just a second, I should go with the second case. So sorry.
Yeah. Why don't we go ahead with the second case then? Anita, do you want to do the second case?
Case?
Yeah.
Okay. All right.
So Professor Anita Agrawal is a retina and uveitis specialist, faculty, long time with Vanderbilt and still jointly with Vanderbilt, and also working in San Francisco now, and very good at this spectrum of disease. We thank you so much for presenting, and we really appreciate it. These are all kind of obscure cases, and so we're presenting more classic ones than sort of difficult ones.
Are the slides
or
visible?
Difficult to diagnose. Yes, I see them anyway.
All right. I'd like to introduce our senior fellow, Dr. Lawrence Chan, who will be joining us after he finishes his fellowship in a couple of months. Lawrence will present the case, and I will discuss some of the atypical features of MEWDS. Lawrence, you can go ahead.
Thank you all for your attention, and thank you, Dr. Agrawal, for being such a great resource and being the closest to a walking encyclopedia as you can get. No disclosures. Next slide. So our case is a 46-year-old female who comes in with temporal flashes and dark spots in her right eye for a few days. About a couple of weeks ago, she had some URI symptoms, sneezing and headache. She doesn't have any significant past ocular, medical, surgical history, and she's not taking any medications. Here's her right eye. Her vision is down to 20/50. Fundus exam shows multiple gray-white lesions scattered across the posterior pole, some isolated, some confluent, surrounding the optic nerve, extending to the equator superiorly and inferiorly. Here's also the left eye, which was asymptomatic and appeared normal. Fundus autofluorescence showed hyperautofluorescence of the creamy lesions. Next. On FA, there are a few areas of punctate hyperfluorescence with late staining and a wreath-like pattern of the macula. Next. In OCT, you can see a few features. There's some disruption of the outer retina with patchy loss of the ellipsoid zone. You can see these vertical flare lines coming from the ellipsoid zone extending through the outer nuclear layer. Some are longer, some appear like clumps. There are also a few vitreous cells seen. Next. So our differential was a white dot syndrome. White dot syndromes, including MEWDS, MFC, PIC, acute idiopathic blind spot enlargement. Syphilitic retinopathy is also on the differential, and AMPI if this was a bilateral presentation. So what is MEWDS? It's an idiopathic inflammatory condition affecting the outer retina, RPE, and choriocapillaris. It's associated with the preceding viral flu-like illness. Commonly affects young, healthy, often myopic females. The acute presentation of blurry vision, photopsias, scotomas, floaters, and sometimes dyschromatopsia in one eye, and it spontaneously recovers in weeks. The prognosis is very good. It's a self-limiting course that often resolves without treatment. No indication for steroids unless it follows an atypical course. And they have excellent visual recovery in most patients, but sometimes partial field defects and photopsies can persist for months, even after the fundus exam findings resolve. For our patient, about 1.5 weeks later, her testing for syphilis and tuberculosis came back negative. And 1 month later, we can see resolution of the lesions and improvement on autofluorescence. And on OCT, we can see the typical restoration of most of the integrity of the ellipsoid zone.
Okay, Lawrence is going to stop here, and MEWDS is a little bit more straightforward than the prior condition that Dr. Gangaputra discussed, because we don't really often have to treat these patients. We just follow them and make sure they don't develop an atypical course, or they're not a masquerade like syphilis that's been missed. So for those reasons, you continue definitely to follow these patients, and within about 2 to 3 months, most of them resolve. I will discuss a few atypical features of MEWDS and a little bit of recent sort of controversial or a new spin to MEWDS. And we have esteemed faculty who can give their thoughts, and I will try to illustrate with one case the overlap between MEWDS and the punctate choroidopathy, azure, and secondary MEWDS that is in the press and hotly discussed in the last couple of years. So this MEWDS is primarily a disease of the photoreceptors in RPE. It affects young myopes, mostly women, and may or may not have a viral prodrome. Generally, it's self-limited, and it resolves without any sequelae or very minimal sequelae. Here, I'll show you a few examples which we could not display in the previous case since we did not have the orange granular dots. These are called Jampol's dots. If sometimes the MEWDS lesions have already disappeared by the time the patient comes to you because they're evanescent, as the title goes, and you may only be left with these orange foveolar dots, and that's another way to make the diagnosis based on the history. And here's an en-face image of this patient who had MEWDS lesions. You can see that the lesions are sort of at the level of the photoreceptors. This was taken at the photoreceptor level and corresponds to most of those creamy white lesions. I will discuss now a little overlap between MEWDS and azure, along with punctate choroidopathy and secondary MEWDS. Secondary MEWDS has been brought up by Dr. Jampol and his colleagues. I think in 2021 is their first publication that patients who have MEWDS generally fall into the category that I just described, but if the patients are either older or they're very highly myopic or they've had prior retinal issues such as pseudoxanthoma elasticum, choroidal neovascularization for any other reason, or is it post-vaccination, all of these are now being considered as secondary MEWDS. And we'll look at that example. This was a gentleman who had retinal detachment repair with a vitrectomy, prior laser for retinal tear, and he had 20/20 vision prior to his presentation when his vision dropped to 2100. He developed photopsias and an enlarged blind spot, and he complained of this temporal field loss. And of course, in our myope, you're always looking for retinal detachment, but he did have these creamy lesions that are much more subtle than the previous example. But I will show you on the autofluorescence, you can clearly see that these lesions are widespread. They're far more, they're going almost up to the anterior equator, and the hypoautofluorescent lesions are from his prior laser scars. So he had a field loss, his vision dropped from 20/25 to 2100. And here's his OCT, which shows diffuse and widespread loss of the ellipsoid and outer retina. Some of them are clumps, some of them are patchy losses. And the outer nuclear layer is preserved, which is a feature of MEWDS, which is why most of them recover. In this example, we could get in both a fluorescein angiogram and an ICG. The ICG in the early phases are generally non-contributory, but as you proceed with the ICG, you can see these dark spots. Though this lesion is not in the choroid, the dark spots are probably because the overlying opacified RPE cells don't let the dye be visible, and hence you see these dots and spots. We don't think that MEWDS is in the choroid, definitely, maybe just the adjacent choriocapillaries, but it's not a disease in the choroid similar to either punctate choroidopathy or birdshot. Fluorescein angiogram in this example shows very clearly the wreath-like hyperfluorescence. The MEWDS lesions are made up of multiple little dots that pick up fluorescein pretty early in the angiogram and can stain or become a little bit more prominent or actually fade in the late phases of the angiogram. So this gentleman's symptoms improved without any treatment for about 3 weeks, but then he came back complaining that his visual field loss was worse and his temporal field loss had now involved more of the central and crossed over to the center. So his vision went from 21/25 to 20/40 and now had improved, and now he's back to count fingers. At this stage is when I saw him. We put him on oral steroids and Valtrex because his OCT did show much more changes on the photoreceptors, though some of them had recovered. A significant area of the nasal macula was still had not improved. Over the next few weeks, he also received one Ozurdex injection and subsequently was started on a course of mycophenolate mofetil. Over the next 6 to 8 weeks, his autofluorescence showed some improvement. It did not resolve completely like one would expect with MEWDS. The hyperautofluorescence improved but remained around the disc. In addition, over the next few months, he developed these pick-like lesions that you can see that were not present in the initial presentation. And you can see them as hypoautofluorescent lesions on the autofluorescence. So over time, his vision improved to 20/25 on the steroids that was tapered over about 5 months. And he was kept on mycophenolate for a little longer. Eventually, all his symptoms stabilized. He was still left with a slight nasal macular photoreceptor loss, and so he had an enlarged blind spot, though his central vision improved. So here he is at presentation in 2019, May of 2019, and this is him about a year and a half or 2 years later with a residual autofluorescent lesions that are hyperautofluorescent lesions that is probably a part of azure. Azure, the photoreceptors can recover if you catch them really early and treat them with steroids and possibly cover with Valtrex, and I can discuss that in the discussion as to why the coverage with antivirals. But azure can result with residual field loss and residual hyperautofluorescent lesions that are present in this patient. So this gentleman presented with exuberant MEWDS, ended up with residual field defect, putting him into the azure sort of spectrum, and also developed some pick-like lesions with atrophy nasal to the disc. So to start up the discussion about secondary MEWDS, in 2021, Dr. Jampol and colleagues described this epiphenomenon of MEWDS occurring in patients who were not usually in the typical age group or typical demographics for MEWDS. This was seen in pre-existing retinal conditions such as CNVM from pseudoxanthoma, Bell's disease, post-vaccination, high myopia greater than -6 diopters, prior retinal surgery, similar to the second patient that I described. And I will stop here and we can go on to either discussion now or possibly, I think we have time for discussion at the end, correct?
Right. Yeah, we're running a little bit late, so let's go ahead and finish our presentations and then we can discuss some more at the end. I'm thinking maybe it's best to go ahead with David's case now, and then we'll have Janet wrap up. So David Seraph is a professor of ophthalmology at UCLA, a retinal specialist, especially interested in inflammatory retinal diseases as well as genetic and other diseases, and well known in these sort of obscure and interesting retinal inflammatory disorders. So thank you so much for presenting, David, and why don't you go ahead?
Thank you, John. I have actually 2 cases that my fellows, my international fellows, Alessandro Feo from Italy and Shaheen Fakihi from Iran, are going to present. Alessandro has a little bit more straightforward case, although I wouldn't call it too straightforward, of placoid disease, and Shaheen has a more interesting one. Hopefully they could take a few minutes just to present those, and then we can discuss the cases afterwards if there's time. So, Alessandro, why don't you go first, and in a few minutes, if you can, show this case of this patient that I've been following actually for many years with placoid disease, AMPI, versus probably more persistent placoid or even relentless placoid, given that he has had persistent interchoroidal ischemia driving his disease. So go ahead, Alessandro.
Sure. Thank you so much, doctor, and thank you so much to the organizers of this beautiful conference. I've just requested the possibility to share my screen in order to share my slides. Please, if possible. Thank you so much. Okay. Okay, perfect. I hope you can see my slides.
Yes.
Okay, thanks so much. So thanks again for the opportunity. I'm very happy to present this case of persistent placoid maculopathy and to highlight the role of choroidal ischemia and ANFAS-OCT and OCT imaging in this case. So we have a 6-year follow-up in this case. We will start with the presentation. This is a 64-year-old male who presented in 2019 with vision loss in the right eye. And this is the colorful ultra-wide field color fundus photography with Optos, so pseudo-color, and you can see the creamy white lesions in the posterior pole of both eyes, corresponding to hyper and hypo autofluorescent changes on ultra-wide field autofluorescence, and of course to these geographic hypofluorescent areas of choroidal hypoperfusion or ischemia on late phase ICGA. Spectral domain OCT shows this typical acute oblique hyperreflective lesions at the level of the outer retina and the Henle fiber layer that the group of Dr. Saraf have named ASH lesions. OCT angular sign of Henle fiber layer hyperreflectivity. Which are thought to correspond in the context of placoid diseases to an alteration of the proximal part of the photoreceptor cells secondary to a primary choroidal ischemia, corresponding to an anterograde process of alterations. So, we will move forward jumping 4 years later. So this patient was actually followed for many years by Dr. Saraf, as typically occurs in this case. This patient developed complications, especially neovascular complication, and we will move forward directly with the color fundus photography. You can see in the right eye a dense area of white material in the macula and some creamy lesions in the left eye. Again, the autofluorescence can show beautifully all the hypo and hyper autofluorescence lesions, and OCT finally shows the presence of a dense area of subretinal hyperreflective material in the right eye and multiple areas of SHREM in the left eye. Notably, moving to the ANFAS-OCT and OCTA imaging, you can see in the right eye the development of these dense and inactive, at this point, type 2 neovascularization in the right eye. And especially on the right, the ANFAS-OCTA slab at the level of segmented at the level of the choriocapillaries shows the surrounding choroidal ischemia or hypoperfusion, which is especially seen as this hypo-reflective area. This is the follow-up. You can see that the right eye is relatively stable in terms of neovascular activity and complications after many injections of aflibercept. And again, this is the choriocapillary slab showing the relatively stable choroidal ischemia, which is a typical feature of this eye. More interestingly, the left eye also has some neovascular lesion. This is again an ANFAS-OCTA slab segmented the level of the choriocapillaries, but focusing specifically on this area highlighted by the yellow circle, you can see that at this moment, which is July 2023, this patient does not have ischemia in this precise area. But if we follow these patients closely with, again, ANFAS, OCT, and OCTA, we can see that after a few months, so from July 2023 to January 2024, this patient actually develops a new area of ischemia, which is visible, which is seen as this round area of hyporeflectivity. And you can also see on the corresponding B scan that some degree of SHREM starts to develop. So this is January 2024. Just in March 2024, so just after 2 months, in the exact same area of the new onset ischemia, you can see the development of a type 2 CMV with SHREM and subretinal fluid. And again, so this patient was, of course, treated with anti-VEGF injection by Dr. Saraf, and this is an overview of the entire process. So from July 2023 to August 2024, you can see that the patient develops this area of ischemia, SHREM, subretinal fluid, and then with anti-VEGF injection, the patient is relatively, of course, stable but improved, and no new areas of relevant ischemia develop in these patients. This is actually the ANFAS OCT, not OCTA, and you can see the development of SHREM and subretinal fluid again. This is actually the last follow-up. We just saw these patients a couple of weeks ago, and you can see that now the area of SHREM is relatively dense, and so it means that the patient is again inactive thanks to anti-VEGF therapy, and so this is the 6-year follow-up. So we have essentially 2 take-home messages in this case of persistent placoid maculopathy. First of all, the primary choroidal ischemia represents the main pathogenesis of this type of placoid disorders. And this type of pathogenesis drives both the development of the superacute H lesions, which were the presentation of this case, but also the development of the neovascular complications, such as the type 2 choroidal neovascularization. And it's interesting that the therapy, of course, requires a dual approach, which both requires immunosuppression and, of course, anti-VEGF therapy. And I think that this case also nicely underlies and highlights actually the possibility of using ANFAS OCT and ANFAS OCTA imaging to non-invasively visualize and monitor these patients, and of course optimize treatment approaches. Thank you so much again for the opportunity.
That was awesome, Alessandro. Dr. Kempen, how long did you want to go on with these cases? I don't have any slides to show. I just wanted to discuss the 2 cases. But if we're running out of time, we can move on to the lecture or discuss this case. Shaheen Fakihi has another interesting case of AMPI that I wanted him to show, but I know that we're running out of time, so I wanted to just get your guidance and how much longer we should go.
Yeah, maybe like 7 more minutes would be okay, because we kind of had some difficulties at the latest, and I don't want to have the material be reduced. And and then Janet also shouldn't reduce her material. Yeah. All right, Shaheen, why don't you get your slides uploaded with the share screen, and I can just quickly discuss this last case. I think it started off as classic AMPI with the placoid lesions that you could see on the color photographs, and the ischemia on the ICGA and the OCTA. The ischemia often corresponds to the ASH lesion, the Henle fiber lesions. The ischemia on the OCTA correspond to the ASH lesions on the cross-sectional OCT. In this case,
I can't see slides. Are we sharing slides? I can't see slides.
Shaheen, can you share your slides?
Of course.
Yeah, he's doing that right now.
David's just discussing right now. Yeah.
Yeah. So the ASH lesions often correspond to the areas of choroidal ischemia. Those areas of ischemia drove the development of neovascularization, and we've been treating those areas of neovascularization, which have progressed over many years with anti-VEGF. But in this particular case, the patient also developed progressive interchoroidal ischemia, and perhaps this was AMPI that evolved to persistent placoid chorioretinitis. And for that element of the disease, we've been treating with immunomodulatory therapy, and specifically CellCept, 3,000 milligrams a day. But this has been a gentleman I've been taking care now for almost a decade, and it just illustrates how challenging some of these cases can be. Probably an AMPI that evolved to a persistent placoid, and then with secondary neovascularization that continues to develop recurrent active disease several years later. So Shaheen, why don't you go ahead and present this last case? This is a little bit more complicated, this case, because this patient didn't present with the outer retinal changes, the Henle fiber layer and outer retinal changes that you see in the hyperacute phase. This patient presented with the RPE changes that you see in the kind of subacute phase of AMPI, and it was only the interchoroidal ischemia that we were able to capture with OCTA that kind of led us to the diagnosis. So in the next couple of minutes, Shaheen, please go ahead and present this case, and then we can wrap up.
Okay, hello everyone, and thanks for having me. It's a great honor for me to present the case here. So our case is a 57-year-old white female with history of multiple anti-VEGF injection, and she had decreased vision in the left eye, and recently she noticed the decreased vision in the right eye to 20/50. This is the OCTA. This is the OCT of the right eye. And when she referred to us, we were thinking about what are these lesions? Are these lesions drusen? So let's dive into this case. This is the fundus photography of the right eye. And here there is a lesion in the macula. And as you can notice, the temporal part of this lesion has a creamy and blurry appearance. This is another OCT of this eye. And in the left eye, we have a particular pattern of the lesion in the macula, and which is more prominent in the upcoming imaging I will show you later. This is FAF of this patient, which didn't provide much more information for us. We performed FA and ICGA for this patient, and we can see the early hyperfluorescence in the temporal part of this lesion. And the other eye, we have this particular pattern, which looks like serpiginoid-like lesion in the left eye. But what helped us to reach the diagnosis was OCTA. In the upper left, in choriocapillaries, we can see the ischemia in the right eye with some satellite lesion around the lesion, main lesion. And these are not related to shadowing, as you can see in ANFAS OCT, the outer retinal layer. Here, the lesion is bright. So all this information made us the diagnosis of macular serpiginous. We started to treat the patient with 3,000 milligram daily CellCept and prednisolone 80 milligram. And after a couple of weeks, the visual acuity improved to 20/25. And after 3 months, you can see the anatomical improvement in the right eye, and also the ischemia in the right eye improved in this lesion. So here is another OCTA slabs of the right eye. And as you can see, the creamy and the blurry edge of the temporal side of the lesion now more clear and evolved to atrophy. Here, there are two articles I would like to talk about, and which was the Alessandro shows the first article. It's from Dr. Klufas, Dr. Sroff, and other colleagues. and the role of OCTA in placoid patients, here the MP patient, and you can monitor the response to the treatment with OCTA and the overlay of the OCTA on ICGA in this patient. Another article I would like to mention is from Dr. Cheng, Dr. Yanuz, and Dr. Sraf and other colleagues. It was a case series of 8 placoid patients, and this is the Henle ash lesion at the beginning of these patients, which evolved to a drosenoid-like lesion in these patients, and which is complicated with neovascularization and the role of anti-VEGF in these patients, placoid patients. Thank you.
That's beautiful, Shaheen. Excellent job, both fellows. Just again highlighting the importance of intracortical ischemia as the driving pathogenic mechanism in placoid diseases like AMPI, and in the second case, macular serpiginous, and also the concept that these lesions start with hyperacute changes in the outer retina and the Henle fiber layer, the ash lesions that Alessandro and Shaheen described, and then they can progress in the subacute phase to RPE changes. And in older patients, these RPE changes can masquerade as AMD. So it's important to have OCTA, not just to capture the intracortical ischemia, but also to identify any secondary complications like CNVM. And that's it. I'm happy if we have a minute or so, if there are any questions about these 2 cases or about a placoid disease to discuss them. But I think that we covered a great deal of territory.
Right. So thank you so much. We are running late, and people can write questions in the Q&A, but I think we better go on to our thematic lecture now. And so thank you, Janet, for joining us. As we mentioned before, she holds the Leach Chair and is Professor of Ophthalmology at Bascom Palmer Eye Institute. Thank you so much, Janet.
Okay, so I think I'm having the same problem with presenter view, which actually I got out of, but let me just check and make sure that I'm not in it. It doesn't seem like I am. Let me try to get back into the regular view again. Is it projecting properly?
Janet,
We're seeing all the
slideshow, but it's okay.
You're seeing presenter view? There's
yeah.
Yes.
Here we go. This should be better. Yes?
Yeah.
Yes.
Perfect. Yeah.
So I'm actually so glad that this is following the case presentations, because it is, they were great cases and they brought up a lot of things to discuss. And this lecture is really completely different, okay? Because it's talking about an overview, and particularly about things like nomenclature and how do we get rid of the term white dots once and for all. I don't have any disclosures that are of any relevancy except sort of a passionate interest in the topic, so you'll have to forgive me for that. So a lot of this work was inspired by, I think, what was an exceptionally successful conference that was put on in Singapore. A lot of people put a lot of effort into this. We had to put on the card that it was about white dot syndrome so that people would know what we were talking. And I think that that is still an issue. But what we have tried to do is transition to the idea of non-infectious posterior uveitis as being what we really wanted to discuss. And I think the cases, particularly that David Saraf showed, show that sort of expanded range of inflammatory diseases that we need to consider when we talk about this class of diseases. So there are a lot of things that we don't know. So here are 3 cases that I would say are maybe look like a non-infectious posterior uveitis, but aren't. This is the middle case is a woman who had chronic variable immune deficiency, and I've seen other cases like this that may be related to multiple past infections. It's really different than a multifocal choroiditis. These are very atrophic lesions, and they progress in an unusual manner over time. The top case is a case that is related to a heparinase inhibitor called fondaparinux, similar to pentasan. It's a class effect of this drug that causes something that looks like AMPI, just a little bit more symmetrical than you would expect to see, but the same type of convalescent change that you see in AMPI, where there is this hyperreactivity of and hypertrophy of the retinal pigment epithelia, creating these hyperautofluorescent scars. And the bottom case is a late onset CEP250 retinal degeneration that has inflammatory features. So the timeline of SUN2 is very important because SUN2 is really the keeper of all of our definitions and diagnoses and all of our research type of classifications of disease. The project was conceived in 2012, which is about when multimodal imaging started taking off. They collected data between 2012 and 2016, including photographs. And Dr. Gangaputra knows a lot about that and may want to say something. They curated the data in 2017. I think at that time, a lot of the images dropped out, did machine learning at 2018, wrote the manuscript in 2019, approved it at the end of 2019. This is a typo, and finally published in 2021. So an extremely long process and for an extremely well done project. Okay, so the project in inflammasio took about 1.5 years. It's still not complete because we're still waiting for our published trials, published papers. And what we were trying to do is actually improve on SUN in terms of looking at imaging to look at a very limited number of diseases. Now, they weren't published very long ago. These are the number of citations that have occurred compared to the original SUN paper. This is a small number, but it's not insignificant. So this is the definition of AMPI and SUN2, paucifocal, multifocal, plaque-like. You get an FA in the acute stages, early and late changes are important. They do not address the convalescent phases, which are I think one of the most interesting findings in this class of disease. They don't discuss ICG, and of course they have this exclusion for infections in all of the SUN2 classification categories. So birdshot and SUN2 really was pauci imaging. They would accept the appearance of something that looked like birdshot lesions. This is challenging for clinicians who are not uveitis specialists. So you didn't even have to have imaging if you looked like this, or if you were at HLA-N A29 and it looked like this, you could say that it was birdshot. But if you couldn't see lesions, which is a rare case, this is just a small percentage of patients in which you see no birdshot lesions, then you would do an ICG, and this was supportive for the diagnosis. And I think this is contrary to the way most of us practice. And we'll go over that in a minute. So multifocal choroiditis in SUN2, they required lesions. They could be punched out or active, couldn't have a lot of vitreous. They had to involve the peripheral retina. Posterior involvement was not needed. For this punctate choroidopathy, which I think a lot of uveitis specialists feel is not a unique disease, it's just a phenotype that goes along with multifocal choroiditis, required involvement of the posterior pole. They wanted only small lesions, and again, they did not want a lot of cellular inflammation. For multiple evanescent white dot syndrome in SUN2, they mentioned the foveal granularity. They mentioned the dots, obviously. They mentioned the fluorescein angiographic appearance, and they did, in fact, get OCT appearance into the SUN2 criteria that were published in 21. Serpiginous choroidopathy, it's called choroiditis in SUN2. They want a shape that is important. They recognize this hyperfluorescent staining at the borders on the fluorescein angiogram in inactive disease. And they recognize that on fundus autofluorescence, an active border would often be hyperautofluorescence. And here is a long-term patient, has some activity at the border of the old lesion, but then a huge new plaque of hyperfluorescent disease, which interestingly enough was treated very promptly and had less subsequent atrophy than the original lesions. So how well do the SUN2 criteria work when you look at them retrospectively? And this is a nice study that was done at the University of Colorado. Very few cases of each of these diseases, more of multifocal, more of birdshot. But they found a high percentage of patients actually met the SUN2 criteria for diagnosis. So they said basically, yeah, SUN2 works. It matches what we call our patients in clinical practice. This other study was done from a group in Korea. They looked at 100 eyes of 75 patients who were considered to have multifocal. 29 of these eyes were diagnosed as multifocal PIC, and 15 were diagnosed as multifocal, and 56 eyes could not be diagnosed as either by the SUN2 criteria. And when you look at this, you can see that a lot of these categories overlap from PIC and multifocal in terms of what the clinicians thought that they were doing. But the ones that don't are segregated out by lesion size and by lesion location, which are those SUN2 criteria, and probably an artificial construct that relates more to pattern recognition than actually a consideration of what the disease is doing to the eye and what it looks like on multimodal. How about perspective? So we have concerns about our ability to diagnose new cases using old criteria and old imaging techniques. There has been an explosion in use of multimodal imaging and non-infectious posterior uveitis to diagnose, detect activity, monitor treatment and course, and detect and manage complications. And this is the outer retinal choriocapillaris complex. And the new field of photopathology is very relevant to our investigations. So this is AMPI as it's defined in SUN2. This would make a diagnosis, no question. When you use multimodal imaging, you get a different appearance. You can look at the OCT, that's not mentioned. You can look at an OCTA, this is the avascular level with some mirroring up of the retinal, mirroring down of the retinal vessels, but this area of hypoperfusion here. You can look at intensity scans, which are interesting on the ENFAS image. If you look at the OCTA of the choriocapillaris layer versus the ICG, you can see that there is clearly choriocapillaris closure, and that it defines this better than the ICG does. So this is probably the gold standard for diagnosing AMPI on the basis of choriocapillaris closure, which we think is probably the pathophysiology of the disorder. Inspired by this, a group of people, about 12 people, have really spent a lot of time doing a systematic review of the literature. We wanted to concentrate on the post-SUN years, the 2018 to 2024, because we wanted to see what has changed since those initial very experienced uveitis specialists looked at this topic and put together their criteria for diagnosis based on what was a very thorough review of images and of diagnoses, and many cases contributed by many people. So we used software, we used a professional research library to help us. We had a very extensive search. We ended up with a final of 70 papers that were included in the review from 2018 to 2024. We had a lot of papers that showed up, and we actually went back and looked more closely between 2012 and 2017, because it became obvious that there were probably some fundamental findings in those years that were informing later studies, and we wanted to make sure that we weren't missing anything. There were some very important papers published, particularly in 2016 and 2015, but also some excellent ones going back to 2012. So these are what we found in the systematic review. It's a bit complicated. Tests performed are actually numbers of patients. It is not numbers of eyes. For AMPI, you can see that the numbers are low. So only from 2018 to 2024, 109 eye examinations, only 14 papers. 5 of those mention MMI. In 2018, in the pre-2018 papers, you have 17 papers, a little bit more interest. And these are the imaging features. So that clinical utility statements for OCT were 2 papers, 2 papers for OCTA, 2 papers for MMI. When you get into a disease like birdshot, there are many more patient exams reported, many more papers. Still, there is more interest in the 2018 to 2024 in terms of publication. More papers are present. You see more clinical utility statements appearing in the 2018 group. You see clinical utility also mentioned specifically by the authors twice for the multimodal imaging to be used in the diagnosis of this disease. Similar findings for multifocal choroiditis, but for both multifocal choroiditis and the papers that segregated out PIC, you can see that there are very large patient numbers here because this is an imaging rich disorder. And there are a lot of patients, probably because there is more heterogeneity in this particular classification in terms of etiologies, I think, than in any other. And I think a lot of the diseases that we call multifocal choroiditis may actually ultimately turn out to be something else. But there's really no evidence that multifocal is different than multifocal PIC, other than, again, by lesion size and lesion location, which is somewhat artificial and can certainly change over time. In other words, PIC can later look like a multifocal choroiditis. It's the same disease process, we think. So here are the papers, and for both MEWDS and serpiginous. Serpiginous, again, a rare disorder. You could also say it's not rare that clinicians and academicians don't have any particular interest in it. So there is some paucity of information about it. Again, that seems to be picking up in the 2018 to 2024 group. So if you want to look at it in terms of just heat maps, it's easier to see. You can see in the dark colors here, this is where most of the patients on the top row and most of the studies are concentrating in multifocal and in MEWDS and in multifocal PIC, rather than AMPI or even in birdshot. The clinical utility statements, again, are focusing on diagnosis for multifocal, diagnosis, activity, and monitoring for MEWDS, diagnosis for multifocal PIC. So these are the areas of interest in publication, and also, I think, availability of case material. So as part of this whole project, there was an interest in how much multimodal imaging do you actually need? And this is not my work, and other groups are going to be refining this, certainly. But in this rather complicated but color-coded graph here, you see the asterisks mean that it's already in sun. For diagnosis, classification, pathogenesis, there's a large number of imaging studies that seem to be important as this was being in this particular working group. For activity monitoring, it remains robust, particularly for birdshot. For detecting complications, it remains very robust. Serpiginous, interestingly enough, has probably the least imaging associated with it of any of these disorders in terms of what we think a regular clinical practice could get by with without needing sophisticated equipment or feeling like they were not adequately studying their patients. The OCTA is really prominent in AMPI. So the validation was attempted. We actually tried to do that at the Inflammatio meeting. And these are the results, basically. Autofluorescence improves sensitivity and specificity compared to color. Autofluorescence was useful in MEWDS. These are all statistically confirmed. ICG improves sensitivity and specificity for diagnosis. And this is interesting. Remember, I mentioned this was not even mentioned in the SUN2 criteria. And multifocal PIC, OCT, OCTA. And in birdshot, it was pretty strong that ICG is a part of the diagnosis, activity monitoring that you need to do while you're following a birdshot patient. So one of the other interesting things is this gap in our knowledge about AMPI, that it's not really being considered. AMPI is usually self-resolving. There are exceptions. MEWDS is self-resolving, but MEWDS gets over with so quickly that there are some papers that do timeline and how the imaging changes, but basically you're seeing this continual resolution. AMPI remains interesting all the way through its course because of this characteristic pattern of RPE hypertrophy. I showed you the heparinase inhibitors. They prevent the breakdown of the extracellular matrix. Interestingly, these things can improve over time, perhaps by the by the help of heparinase to cause the tissue to remodel. That's a phenomenon that we always see in RPE scarring. And obviously this has huge visual acuity prognosis for it. So I think the next steps here are that we want to validate the clinical utility of MMI. How much do you need? We don't want to get 6 imaging modalities on every patient. It's not financially feasible to do that. Many centers won't be able to do it. We want to explain cases like this. Maybe that's a pre-existing Azor with a secondary MEWDS, but these spots haven't changed over the last 10 years. Here's an acute enlargement of the blind spot syndrome. Is that a variant of AMPI? There's a lot of work that still needs to be done. So that's what I prepared for you. I hope that it's amplified some of those really excellent cases that were presented. So John, back to you.
Great. Well, thank you so much, Jan, and all of you for presenting cases. Now I think we can be open for discussion for maybe about 10 or 15 minutes.
May I ask a question of David Saraf?
Sure.
Okay, so you showed you mentioned that it was possible to follow patients to treat patients just with anti-VEGF without giving them any immunosuppression after a certain point, and you were getting good clinical results, which I truly believe, that you are seeing a response. But then you show a case of this placoid lesion in which there is progressive choroidal ischemia. And I'm just wondering, could you comment on whether or not an anti-inflammatory or immunosuppressive therapy could have helped prevent that, or perhaps reduce the need for anti-VEGF injections so that they did not have a chronic condition, or in the second case, that they did not have a progressive choroidal ischemia? That's a question.
Yeah, the first case, actually, we started immunosuppressive therapy right at baseline. And the patient developed neovascularization relatively early in his course. And the progressive ischemia was very aggressive in the first few months of his disease. So we started him on CellCept early. I think he then he had a rheumatologist and then encountered some systemic issues. And we stopped it. And then he began to develop more evidence of progressive choriocapillaris shutdown. And so we restarted the immunomodulatory therapy. So in his particular case, we actually diagnosed persistent placoid relatively quickly and tried to get him on board with immunomodulatory therapy. His disease has still progressed, but the right eye now has really kind of settled down. The left eye had that recurrence that Alessandro described, but right as of today, he's on CellCept therapy. We actually increased his dosage. That was another adjustment that we made. The patients I was talking about with anti-VEGF are, of course, the PIC patients. Those ones, in my experience, they often have the acute infiltrative lesions, often show flow on OCTA. I treat them with anti-VEGF, and then they settle for indefinitely for many years. I don't know what your patient experience is, but many of my PIC patients don't need immunomodulatory therapy. I have a few that I have used it, but oftentimes I'll see neovascularization correspond to an active lesion. I'll treat them with anti-VEGF, maybe a treat and extend protocol like Sapna suggested, and then they're latent for many years. Is that your experience as well, Janet, with PIC?
Well, I think the problem with both PIC and MFC is that it's actually a sporadic disease. And so the decision to start and to continue immunosuppressive therapy is somewhat more difficult than something like birdshot, which is much more likely to be a chronic disorder. Right. So it's difficult if you're treating someone with immunosuppression to know whether they're just quiescent and they're in between episodes, whatever the trigger is for these unusual choroidopathy type of diseases, or whether in other words, whether treatment is necessary or not. But I think that for a lot of people, and I know Bailey Freund in New York feels this way, that if there's an active CNVM, it should be a combined therapy, at least initially, to reduce inflammation. That the CNVM is coming from an inflammatory drive, and therefore without anti-inflammatory treatment, the anti-VEGF may work, but the solution to the problem may more rationally include an anti-inflammatory. And I'd be extremely interested. I see that Dr. Gangaprucha has her hand up, so she wants to.
Before Sapna speaks, I think we have a lot of our attendees from Sub-Sahara and other regions where they may not be able to look for CNVM in PIC using OCT angio. So I would like to get opinion from all the panel one by one as to how would you suggest them treating PIC when they diagnose maybe OCT, clinical, minimal imaging, and they can't really monitor for CNV. What would be your first line of therapy? Because there were questions related to would you give biologics as first line or would you give methotrexate? So let's start with you, Sapna.
So if I didn't have OCTA, but I have an OCT, then I'll monitor with OCT. And if I see active lesions, then I treat with corticosteroid. If I see CNV, I might add adjunctive anti-VEGF until the CNV fluid resolves, but I would treat with prednisone. That's my primary.
Would you add immunomodulatory like azathioprine?
Not until I see several relapses or a chronic course. As Dr. Davis said, it is typically sporadic, so I would treat that episode. Many a times I've done a PSTK and an anti-VEGF on the same day, or oral prednisone and an anti-VEGF on the same day, and then I monitor the patient until that prednisone is tapered off, and then I just monitor the patient every month or 6 weeks to see how it changes. I will not put immunomodulatory therapy as the first line.
Anita?
I agree. I think every case has to be sort of taken by its own merits and its own features. The few things that I would say is if you ever suspect PIC at the initial, whatever time, the first time the patient comes, get a fundus photo and autofluorescence along with everything else that you do. Because quietly these guys get new lesions over years, and sometimes you think, oh, there are 10 lesions there and they were already there, but then you discover there were actually 6 initially and now there are 10, 11. So quietly these PIC lesions and multifocal choroiditis lesions can kind of pop. That gives you an idea over time. If that's happening, then you may need to do something more than just treat them at the time of their episodes. And they can be variable. They can just have scars, have nothing at all, and you just tell them you come back once a year. It's important to those ones that have CNVM to give them an Amsler grid or something else that they can sort of catch any recurrences. And I treat them depending on, I think if I see there's a lot of subretinal hyperreflective material, I would give them a little bit of steroids, maybe for 4 to 6 weeks, and then give them the anti-VEGF. And then if they're quiet, I don't have to do anything. I do couple more anti-VEGFs, extend it fast, and then watch them. But if they've had multiple lesions, their CNVM is very close to the center. I've had some patients on immunosuppressants for some years and get periodic anti-VEGF. So it's all sort of variable. And the most important thing is to recognize that somebody has quiet lesions that are completely inactive, never have any problems, and the other ones that may have frequent or recurrent episodes of either new lesions or CNVM.
Thank you. So Janet, you suggested that since it's an inflammatory and CNVM is going to recur because of inflammation, you got to treat inflammation. So would you give immunosuppression right in the first episode, or would you wait for request?
Well, I'm going to go back to your original premise that I'm in sub-Saharan Africa and I have only my clinical skills and I have very limited medications. So if I would use visual acuity, Amsler grid, and my slit lamp examination with a handheld lens to determine whether or not I thought there was an active lesion in the macula. And sometimes you'll see very definite clinical signs. And again, in a situation where I had very little else to go on, if I thought there was an active lesion by change in vision, Amsler, or a clinical appearance, I would give an acute dose, an oral pulse dose of oral prednisone of 60 milligrams a day for 14 days only. This is often enough to quieten a lesion. Obviously, some people are going to behave differently, and they're going to have chronic disease, and they're going to keep getting new lesions. That's a different issue than the first question that you ask. I think knowing whether there's a CNVM there is almost a frill. I think control of inflammation should reduce the risk of that, except for very susceptible people like myopes and older people. If anti-VEGF is available, some people would make a case that you, particularly if you can't tell with sophisticated imaging exactly what's going on, that you would just treat with both things first and see what happens. I prefer to treat first with the anti-inflammatory high pulse dose, quieten the lesion, see what happens, and then chase it with an anti-VEGF and basically see which works best. And so that's somebody just basically, you're trying to just be a clinician and do what seems to be working. Low tech, so the only advantage of that particular approach.
There have been a couple of questions on the use of biologics. Would anybody in the panel recommend using biologics for any of these entities? Any of, like, let's include all of them. Any one of you would use it as a first line? Because there were almost 4 or 5 questions related to that.
No, not as first line.
David?
Only if chronic and I began an antimetabolite and they failed antimetabolite, then I might add a biologic to that.
Yeah, I
David,
agree.
would you?
And the only time I've added biologics for all the the immunosuppressives either failed or only partially is sympathetic ophthalmia and really bad birdshot. Most of them, birdshot, 90% of them are on methotrexate and they do very well. But a couple of them have either not tolerated the methotrexate or the effective dose isn't good. One advice I have is, now that I've learned that injectable methotrexate has a little bit better bioavailability, so if oral methotrexate is not working, you can try the injectable before you go to biologics. So you can still control treatment by yourself and you don't need a rheumatologist. Once it goes to biologics, I definitely ask for a rheumatologist to take over managing that part of it.
Okay, so David, I have a question for you. How important, I know you are a multimodal imaging guy, but think of the people who do not have ICG. How important is ICG to diagnose and to monitor response to therapy? Leave birdshot aside, the remaining 4.
Yeah, well, I mean, we have to look at the particular disease. For PIC, of course, I don't use ICGA. For the placoid diseases, I think OCTA is actually sufficient, and we showed that in that Clufus paper. The OCTA lesions correspond to the ICGA lesions. I like to get it just as further confirmation, but I think the OCTA can show you the choroidal ischemia, and it's non-invasive. It doesn't require a dye injection, and you can repeat it to assess a response to therapy. So I prefer OCT and OCTA over ICGA for all the placoid diseases, but it's a nice instrument to have because it does illustrate the areas of non-perfusion very well, and it gives you wide field capability if you have the opto system. For MEWDS, again, MEWDS is a nice, I think Anita's case illustrated the benefit of ICGA and MEWDS. In the late stages of the disease, ICGA is not uptaken by the RPE in the areas where the spots are. And that's a very important pathophysiologic concept. But again, the OCT and the on-FOS OCT, and I believe Anita showed a very nice example of the hyporeflective spots with the overlying hyperreflective dots. I think those are actually very diagnostic as well. So I don't know that you need ICGA in MEWDS necessarily. I think the OCT, and if you're very sophisticated, the on-FOS OCT can be very helpful to arrive at the diagnosis. Perhaps the most important disease is birdshot, I think, for ICGA, because sometimes
let me just mention regarding the previous question about biologics. Russell Reed also put in the Q&A that basically you can't get it with insurance as first line for these things. So at least in the US, and I think that would be true in much of the world.
So can I make a comment about the ICGA? Everyone's saying, except for birdshot. Birdshot is completely different. It's really not in the same category as these other diseases. It's artificially been placed there as a white dot because it has spots, but those spots are deep in the choroid. And they're actually pretty much beyond the type of imaging that we're talking about. So it's no surprise that we're finding that the OCTA and the OCT and the autofluorescence and things that concentrate on the outer retina are in fact superior for the other diseases. You can see findings on the ICGA, but it's not as essential as it is in birdshot, where I think the other imaging, David, I hope some point you're going to be able to tell me I'm wrong, but that the OCTA is sufficient in birdshot to monitor those choroidal lesions, which I think have to go away. You have to get those to go away with your treatment to feel like birdshot is actually in remission. So can you do that yet, David, with OCTA?
No. We looked at Gary Holland put together a group to look at about 70, 80 patients, at least with OCT and birdshot. And the OCT will tell you identify some degenerative changes in the inner and outer retina. You can actually see some hyporeflective lesions on the OCT that don't correspond actually with the spots that you see on color fundus photography and ICGA. So the OCT and OCTA are very insufficient for birdshot, which is exactly what I think you were highlighting. That's exactly correct. The ICGA is a much better tool in that regard.
I was going to mention that I use OCT in birdshot to look at the choroidal thickness. Even when they first come in, if they've not been treated, the choroid is so congested and thick. And using, in the past, we used to get a baseline Goldman visual field, a baseline ERG, because we were worried that they'll all progress. But birdshot, if you control them well in the first few months, I think they do very, very well. And just an OCT, measuring the choroidal thickness and looking for any extra congestion in the choroid is a good way to monitor birdshot.
Janet, so when you treat your birdshot patients, a biomarker of successful response is you require elimination of the choroidal infiltrates by ICGA. Those should have to disappear, otherwise you will increase therapy.
Yes, they have to disappear. The retinal vasculitis has to disappear. Anita's point is very well taken. And over time, this can be a progressive degenerative disease that doesn't even respond that well. It could be from past damage that has accelerated aging. And all of these patients, they present in middle age and then they quickly get older. And I think that takes its impact. You can see hyporeflective choroid and thinning of the choroid as people tend to degenerate, as well as those outer retinal degenerative changes that you mentioned, which sometimes are in acute patients. But I have patients, birdshot is an extremely slow disease. So I have patients that I've treated for years with immunosuppression. I'm now treating longer and longer in this group of patients. The birdshots completely disappear. I think they're in remission. 2 years later, I do another ICG and the spots are back. So I think it is a very important marker of whether you have achieved clinical quiescence in the disease. And I continue to monitor them with it as well as the FA for every year at least.
That's very interesting because I think some people would suggest just using functional biomarkers like visual field, perhaps as a way to assess progression, or ERG as another way. But you think in addition that even if the patient's functionally stable, it's still very important to eliminate the choroidal lesions that you see on ICGA.
Well, I think so I have seen a lot of birdshot patients, and I have patients who have actually lost their vision completely from birdshot, either because of lack of treatment. I may have inherited them from Dr. Gass, who really didn't believe in immunosuppression or even in corticosteroids for treatment. Because it is a slow disease, you can feel like they're doing all right. Even if you monitor with ERG, it has a high intertest variability. So it may be difficult to detect what's going on. Once you've gotten to the point where you're losing substantial pigment, the choroid is thinning and it's becoming hyporeflective, it can be difficult to reverse the process. So I don't think there is another good biomarker. It's an assumption. I think it's the choroidal disease that blinds patients in birdshot. It's the hardest to treat. And I think the only thing that you can do preemptively is to try to reduce those choroidal inflammatory lesions so that they don't get into this chronic degenerative stage. So I tell them every year you can take at age 65 is a year I don't have to treat you when you're 85. So I'm giving you another year of vision, 20 years down the road when you're too old to take treatment.
I agree.
I don't know if that's true, but that's the new way I've been looking at it.
There is a question by Russell Reed that how would you differentiate active birdshot on ICG from scarring other than the active lesions disappear? David, would you take that? Yeah, Janet, go ahead.
No, my answer is I don't know. I don't have a good way to do that. Sometimes it's a guess. They look a little different, but it's hard to say. I'd love it if David would say something or someone else.
Yeah, I
Anita?
have more experience with birdshot than I do, but certainly people make this important observation that the acute lesions, you're right, they regress with therapy, but over time the lesions can become atrophic, and those are more permanent. So I guess I would say that they have more of an atrophic appearance on fundus exam. They tend to be more atrophic, wider, perhaps maybe even larger. But I'm not sure that perhaps is a good study to be able to look at the lesions acutely versus the chronic lesions and develop clues to the differentiation.
So those spots that seem different and seem brighter are actually where you've lost choroidal pigment. So that's completely different than what we're talking about. Anita, I'm sorry, I interrupted.
Tell, I started treating birdshot when I took over, when I started my job in 1999, because prior to that, as Janet said, I think Dr. Jampol and Don Gass would only treat those patients who had complications like CME or something else. And they were all just monitoring them. And over time, they all get retinal changes, vascular narrowing, and things like that. But anyway, bottom line is, I have patients now for 26 years that have done really well. It's important to first catch the birdshot early. And I think those ones that come late because people thought they have PVDs and they ignore the floaters and things like that. Somebody did vitrectomies to get rid of floaters, and then you discover they actually have birdshot. I think if we really catch them early and you give them immunosuppressives, good dose as steroids and immunosuppressives, and keep them on steroid for a few months and then the immunosuppressives for time, and gradually decrease the immunosuppressives. I've had several patients with no CME, no loss of color vision, nothing, and their ellipsoid line is intact. And I think that's a good way to do it. But I think it's critical initially, if they were missed for a few years, those are the ones that don't do well. The ones who come in with already photoreceptor changes, autofluorescence changes, that means they've already affected their outer retina. The one thing that I have is the puzzle about birdshot is on the ICG, you see all those dark spots. You can't catch them on any other imaging. You can't catch them on OCT. I don't know if David has any high resolution OCTs that he can find those lesions. I don't know what they correspond to. Why are those black dots on ICG that you can't really find on anything else? They're not.
So the one histopathology.
Are they sort of clumps of lymphocytes or some kind of inflammatory cells that are sitting in the choroid that we can't really see on any other imaging, but only can see it on ICG?
I was going to say you can see it on histopathology. And I think there's one case, maybe two cases. These are clusters, not granulomas, but just clusters of T and B cells, a mixed inflammatory reaction. that are around the large choroidal veins. And I've heard the comment made by someone who's examined the specimen that they are actually oval shaped and point towards the optic nerve head. So there's some sort of tropism there in terms of the inflammatory reaction, but it's why I think the spots are real. I think it's a filling phenomenon, right? That's why it's dark, because they are inflammatory spots, and that's why they go away with treatment.
Yeah, which I think some of the darkness in other diseases that are dark on ICGs, all not choroidal hypoperfusion. I think a lot of it is choroidal inflammatory cells in addition to some secondary non-perfusion or compression of the vessels like sarcoid. You know, you see this granuloma, it looks dark on the ICG, you treat them with steroids, everything comes back. It's not like they have hypoperfusion or such a thick area of the choroid. I think it's inflammatory cells. So every time we say ICGA and choroidal hypoperfusion for everything, how can you have choroidal hypoperfusion for so many diseases and they all get better, or at least some of them get better? And I'm sure there's a lot of inflammatory cells in there. And
so majority of them are and which just disappear. And I think Russ has a very important point that please do not keep injecting Ozidix for birdshot, because
it reactivates and quiets, reactivates, and gradually gets worse and worse. Yeah.
That's a very
I wanted to just ask about the classic serpiginous and tuberculous serpiginous. How do we tell the difference?
Well, you want me to answer? I can take that.
We have the world's expert.
If
better ask her.
Yeah.
If you see clinically, if you see any cells in the anterior chambers, cells in the vitreous, that's not classical, because the classical doesn't have inflammation. If you see the location, the classical one is peripapillary, whereas the TB one is multifocal and it's in the posterior pole. It does not have that classical peripapillary location with pseudopodia-like extension. No, it is just multifocal lesions which are coming in the periphery or in the posterior pole, and you have the center which is more healed and the periphery of the lesions is more yellow. It's not only the tip, like the classical serpiginous, which is pseudopodia with the tip-like progression. These are round lesions, and they have the center which is healing and the periphery which appears yellow and active. If you do fluorescein angiography, you may see leakage from the vessels, which doesn't happen in classical. You may see capillary leak, you may see leakage from the vessels, which all these markers are indicative of TB or any other serpiginous like, that it's not true serpiginous.
Right, and they would also have positive tests. Yeah.
Of course. I'm just talking about when to suspect. Yeah.
And I have a question for David. David, the first case that your fellow presented, did you think it was APMPP that kind of became a little bit atypical? Or do you think it was because the vision got to 2020, 2025? I mean, yes, some persistent placoid can get back good vision, but they did develop choroidal neovascularization down the road. And do you think you kind of, is it like a sort of an atypical case that was that sort of blended from one to the other, or you think it's distinctly?
You're right. I mean, I saw him just last week. His vision now is 20/40 in the right, 20/30, 20/40 in the right, and 20/25 in the left. He's still doing well after, close to a decade of oversight. But AMPI, you're right, can progress in the first week. And certainly it started out like AMPI, but given the aggressive neovascularization that he developed, he's also a little bit older towards 60. And then he began to develop areas of ischemia outside the initial, 2 to 3 months when we first started seeing him. I think the diagnosis became probably more consistent with persistent placoid. But AMPI can, in the first week, progress. You can see, as you guys all know, you can see, limited lesions, and then suddenly in a week, there can be many more lesions, and that's how he initially presented, and I think that is consistent with AMPI. But after several months, he continued to show significant ischemia and a very aggressive course of neovascularization. So that's why I think we adjusted the diagnosis from AMPI to persistent placoid.
Okay, well, thank you, everyone. I think we better wind up. Just to announce next month's session, Alejandra, are you able to share the flyer?
Yes.
Good.
Okay, so you are invited to our next session, our next grand rounds, the round 16, which will be held on June 14th on systemic therapy for non-infectious uveitis. We will feature the participation of outstanding experts. Please sign up.
Okay. Well, thank you, everyone, and I greatly appreciate the contributions of all the panelists. And it was really a fascinating session. Sorry to go kind of long, but the discussion seemed to be interesting, so I let it continue. And we'll look forward to seeing many of you next month as we move to something about treatment. All right. I think we better sign off. So thank you very much.
Bye.
Have a wonderful day.
Thank you, everyone.
Bye-bye.
Bye.
Thank you very much.